Hello and welcome to Unstressed. My name is Dr. Ron Ehrlich. Now, before we start, I would like to acknowledge the traditional custodians of the land on which I'm recording this podcast, the Gadigal people of the Eora Nation, and pay my respects to their elders, past, present, and emerging. Now, today we are going for the annual heart checkup, and every time we do this, on a regular basis, I learn something new absolutely each and every time. And my guest today is my old friend, Dr. Ross Walker. Ross is an integrative cardiologist practicing here in Sydney, Australia. As you will hear, he's a prolific communicator on radio, on television. He's written many, many books. We will have links, of course, at the end of this show to his website. But he is just such a wealth of information. I so enjoy talking to him. We cover a very wide range of topics. I hope you enjoy this conversation I had with Dr. Ross Walker. Welcome back to the show, Ross.
My pleasure, Ron. It's always a great pleasure to see you, my friend.
It is too. Now, listen, Ross.
And let me say for everyone listening, you are one of my oldest mates. Went to school together. We're good mates for years and years and years.
Ross,
far too long.
That goes back now. Well, we go back beyond 50 years now, it would be, since we walked into high school in 1968.
Yep.
Do the maths on that.
Just on that, I now have re-established a really strong friendship with John Stanley, who we went to school with. Well, that wasn't his name at school, but he's on 2GB and I'm on 2GB, and I do a segment. I'm doing a segment with him tonight, and so it's great. It's just great to reconnect with all my old mates from school.
Yeah, well, he's been on the radio for 20 or 30 years at least now. Yeah. And Ross, actually, it's a good opportunity to tell me a bit more about your radio show, because I cannot believe how you pump that out once or twice a week now. What is it?
I do my own show 2 hours a week on a Sunday night. Shameless plug. 7 o'clock on. It's a national show, so it goes to every capital city. 2GB Sydney, 4BC Brisbane, 3AW Melbourne, 5AA Adelaide, and 6PR in Perth. It doesn't, and 2CC in Canberra. So it doesn't go to Tasmania or the Northern Territory, but it's a national show, and it's just it's called Healthy Living, and we talk about anything. So anything medical. I take medical calls, and I do that for 2 hours a week. But I also do segments with John Stanley every week on 2GB. I do 4BC every week. I do PR, I do 3AW, so I do a lot of radio. I also do a segment on the Super Radio Network on a Tuesday, which goes to 5 regional stations.
And you are a working cardiologist as well, which
I still heal the sick. Yeah, I see patients 3.5 days a week, so I do a lot of work in my own practice.
Now, interestingly, Healthy Living, of course, has been around for a long time, and my old friend Susie Yates used to do it before you took it on, I think. And I know that I had a regular guest spot there once a month doing talkback radio. So we'll come back to that later, Ross. We'll see how this interview goes. Now, listen, this I see as a regular checkup for my listeners, heart health, and we're going to be talking about other stuff as well. But at what age should someone consult a cardiologist?
Yeah, I think it's a very good question. I'm not sure that everyone needs to see a cardiologist, but I do believe everyone needs to be very, very cognizant of their heart health. So I basically say that all males at 50, all females at 60 should have a test called a coronary calcium score. Now, the coronary calcium score is a CT scan, so using standard CT technology with the software package to be able to do the calcium scoring, and it measures how much muck you've got in your arteries. Now, I've got to make a very important point here. Unfortunately, this test has been bastardized by many cardiologists and radiologists totally inappropriately to be a CT angiogram. Now, it's the same technology, but the difference is with the CT angiogram, you're injected with a contrast dye. It's more radiation. And what I say, the difference between coronary calcium scoring and CT angiography is the CT angiogram makes your wallet $500 lighter, because neither of these tests are covered by Medicare. Also, you glow in the dark for 3 days after the CT angiogram, because it's typically more radiation, unless you're using one of the latest and greatest machines that are very high slice and very low radiation. And also, you're getting an intravenous dye with a CT angiogram that you can have an anaphylactic reaction to, and in older people, especially diabetics, can damage your kidneys. So, and the other interesting thing is that at the study in the Journal of the American College of Cardiology, where they compared head-to-head in asymptomatic people, so we're not talking about people who've got chest pain, it's a different issue. But when you look at the two studies head-to-head, the coronary calcium score, even though it's cheaper, everything else, and it's less radiation, no dye, is a better predictor. So why on earth are doctors still ordering this CT angiogram on people? I just don't see the logic, and there is no science behind it. So I use the coronary calcium score to tell me how much muck there is in the wall of someone's arteries. And I did a debate the other night for ACNAM on cholesterol. Are doctors getting it wrong? And we're on the side, of course, of saying doctors are getting it wrong, because I don't treat cholesterol at all, Ron. I treat risk. And the best indication of risk is your coronary calcium score. So just say you come to me and you say, look, I'm a 45-year-old male, but my father had a bypass at 40. I do a coronary calcium score and you at 45. But if you were, say, 30 years old and you just want to know about your heart health, it's totally inappropriate to do a coronary calcium score. Now, I'll give you an exception there. I had a young woman whose cholesterol was 12.4, and her father died at 31 of a heart attack. So she clearly had familial hypercholesterolemia, which is only about 8% of heart disease. So it's not that common. 1 in 250 people have this condition. I sent her downstairs for a calcium score, and her calcium score was already 48. Now, that's only in the middle of the mild range, but it's a huge amount for a 32-year-old. I would suggest to you that 98%, 99% of women in their 30s have zero calcium scores, which is why it's another waste of time. And also, Ron, I've got to say, there's only 3 advantages of being over the age of 50. 1 is wisdom, so it's good to have a bit of this in terms of wisdom. 2 is grandchildren if you have them. And 3, you lose the cancer risk from medical radiation. So having a CT scan or having an intravenous CT angiogram over the age of 50 probably won't cause a cancer 15, 20 years down the track. But you have a CT scan, especially with contrast, because there's more radiation in your 20s and 30s, there is the weak potential, not huge, but the weak potential to induce a cancer 15, 20 years later. So I think the first line of the Hippocratic Oath, as you well know, Ron, is first do no harm.
Yes, that's a timely reminder, Ross.
Yeah, so I think we should certainly not be doing any harm. And also I think that maybe age 40, it's good to have extensive blood tests, looking at your cardiovascular risk, and not just cholesterol. Cholesterol itself is a very weak marker, but we do a full lipid profile, cholesterol, triglyceride, HDL, estimated LDL. But I also measure a thing called lipoprotein little a, because this is one of the points that I made the other night, along with Asim Malhotra, who's the one of the prominent cardiologists in the UK, and we're on the side that cholesterol is being overdone. The point we made is that 70% of heart disease is due to insulin resistance. 30% of Caucasians have the gene for insulin resistance, 50% of Asians, and close to 100% of people with darker or olive skin carry the gene for insulin resistance. So insulin resistance explains 70% of heart disease. 20% is explained by lipoprotein little a, which most doctors have not even measured. I've been doing it for 25 years, measuring this. It's the cause of 1 in 5 cases of heart disease. And if you have a high lipoprotein little a, your risk for a lifetime cardiac event without treatment is 70% higher than the next guy. So there's 90% of heart disease explained by 2 genes.
Mm-hmm. Now, it's interesting because I know you've been talking about coronary calcium CT score for over 20 years, I think, and I was sitting at my desk about a year or so ago when you were last on, because I get the Australian Doctor, and the headline came through: coronary calcium CT score now accepted as the gold standard. And I sent you that message to say, Ross, big breakthrough here. Big breakthrough. Now the profession, 20 years after, is accepting that as the gold standard. And look, let's say somebody has a higher coronary calcium score, and without breaking patient confidentiality, I remember we did a program and you said anything over 400, don't read Tolstoy. And I went off and got my coronary calcium score, and again, a bit of a breach of patient confidentiality here, but my score was 650.
Yep.
Now, that's pretty high, and I stopped reading the book immediately. I found it too heavy to lift anyway. But tell me
Yep.
about scores and their relevance.
Okay. They're relevant to tell you you've got a problem that needs management. So a big study out of the US done by Professor Valines from Philadelphia looked at just over 13,500 people followed for 10 years and basically categorized them based on their coronary calcium score. Now, I introduced coronary calcium scoring in conjunction with the SAN and Dr. David Grout, another cardiologist, in 1999, but unfortunately, science advances funeral by funeral, and to get it through the skulls of people that this was back then it was the best predictive test, but now people are starting to accept it, but again, bastardize it to the CT angiogram. So basically, it gives you a number, and the number you want is 0. It's like your golf handicap. You can't get better than 0. If you have a 0 calcium score, this study from Professor Valines showed that there is 0 benefit from being on a statin. So I don't care if your cholesterol's 9. If your calcium score is 0, you do not need a statin. I mentioned FH before, familial hypercholesterolemia, which affects 1 in 250 people. The studies show that 50% of people with FH will have a vascular event by age 50 if they're not treated. But if you're an optimist, that means 50% won't. So I gave you the story of the 32-year-old with a calcium score of 48. I'm hammering her with a huge dose of statin, but I've got a woman in her late 50s came to see me, having been on statins, can't lift her arms from muscle pain, sent her downstairs with a cholesterol of 9.5, her coronary calcium score 0. So I said to her, look, you don't even need a statin. So for the next 8 years, every scaremongering GP said, I'm not saying GPs are all scaremongering,
No,
but these ones
yeah.
were, said to her, if you don't take a statin, you're going to
Yeah.
die. She listened to me, not to them, came back at age 66 with a cholesterol of 9.5, sent her downstairs for another calcium score. Have a guess what it was? 0. So she doesn't need a statin. 1 to 10 is trivial, so that's the same risk as being 0. 10 to 100 is mild. So again, the studies show, Professor Valines' studies show, if you're below 100, you do not need a statin. You've got to treat, wait for this, if you just say your calcium score is 60 over the age of 50, you've got to treat 100 people for 5 years to prevent 1 heart attack with no change in death rate, whether you're on a statin or not. So there's no statistically significant benefit from being on a statin if your coronary calcium score is below 100. But when you go from 100 to 400, that's where you only have to treat 12 people for 5 years to prevent 1 heart attack. So highly statistically significant. That's when I start statins. If your calcium score is above 400, then that's the don't read Tolstoy. If you don't have treatment, I use statins in those people. I use blood pressure therapy. Of course, I look at lipoprotein delay and all of those things. And interestingly, as I said, doctors haven't shown any interest in lipoprotein delay until the last couple of years. And you know why, Ron? Because they've got a drug now for lipoprotein delay. Now, I've been using a combination of vitamin C, vitamin E, and lysine, a la Linus Pauling, for vitamins for high lipoprotein delay for the last 25 years, with great benefits to my patients. I haven't got a randomized controlled trial of this, but I've got a bucket of clinical experience where my patients have done very well on this combination.
That was, Ross, that was vitamin C, vitamin E, and lysine?
And lysine, 1,000 milligrams of lysine.
Which is an amino, is that an amino acid?
Yeah. Amino acid, yeah. And it blocks the lysyl residues in the LP delay locking into the wall of your arteries. Vitamin C, a gram twice a day. Linus Pauling used a lot more than that. And I use the new tocotrienol form of vitamin E in the evening because I use C and E together. They're blood brothers. So vitamin E doesn't work as well unless you throw vitamin C in it. And there was a meta-analysis of vitamin E published, I think, in the Annals of Internal Medicine in 2004 by a guy called Edgar Miller, where he said vitamin E in high doses may be harmful. But what he did is he analysed 11 doses of people using 400 international units of vitamin E or higher by itself, and 3 where they actually combined it with vitamin C, but they all used synthetic vitamin E, DL-alpha tocopherol, which I agree shouldn't be used. It may be harmful. But when you look at the only 2 studies that have ever been done using vitamin E natural, so D-alpha tocopherol or the tocotrienols, combined with vitamin C, one called the ASAP trial and the other one called the IVA study in different groups, but both showed after 12 months in one study and after 6 years in the other one, a 25% reduction in the progression of carotid atherosclerosis, so a surrogate marker for heart disease, in people who just took these simple vitamins. So it really annoys me when doctors say, oh, these things don't work or they're dangerous. So I use CE and lysine for elevated lipoprotein in low-risk people. So just say someone comes to me, the calcium score is 0, their cholesterol's up, their lipoprotein is up. I will give them CE and lysine and leave it at that, tighten their lifestyle, okay? But if their coronary calcium score gets above 400 and they've got a high lipoprotein at the moment, I use nicotinic acid.
I was going to come to that because B3 was something, that's B3, isn't it?
Yeah, B3. Yep. It's the pharmaceutical version of B3. Now, I'm moving into the anti-aging space, and the work of Professor David Sinclair, who's an Australian from the University of New South Wales, who now lives in Harvard. And he's written a book called Lifespan, a very elegant book, simple book to read, very good book on anti-aging. And he's talking about these revved up versions of vitamin B3, which include nicotinic acid, which include NAD riboside and NMN. And so I'm working with some companies to develop this as anti-aging treatment because I think it's very important. Dave's demonstrated a 20% improvement in lifespan in laboratory animals treated with this stuff. Now, obviously, you can't do a 50-year randomized controlled trial in humans. That's impossible. But you can look for the surrogate markers that were present in the animals that were studied, and he's demonstrated exactly the same benefit in surrogate markers in people taking the revved up versions of vitamin B3. But just getting back to the lipoprotein delay, and this is why doctors are now showing interest, we now have a drug, a thing called an antisense oligonucleotide, which is a monthly injection that modulates the production of lipoprotein in the liver. Professor David Sullivan, who's one of the Australian experts on cholesterol issues, works at Prince Alfred. He's now doing a trial at Prince Alfred on this. There's a worldwide trial that David's involved with, which is looking at the mortality rates for lowering Lp(a), so whether you can markedly improve death and cardiovascular events. So it's a 3 or 4 year trial that's being done at the moment. We've already shown with this antisense oligonucleotide up to an 80% reduction in lipoprotein with the monthly injection. But here's what I think is fascinating about what's happening in medicine, right? I think we're going to look back on this era in about 10 years saying it's barbaric, because I think what'll happen is if you're on 2 or 3 pharmaceuticals and 3 or 4, 5, 6 supplements every day, you'll be able to, the chemist of the future will become the chemist of the past. You'll be able to take that prescription to your chemist who'll put it in 1 nano pill that you swallow once a day. So instead of taking 10 or 15, 20 pills a day, which many people are doing, I saw a man in my practice yesterday who's 70, he's poorly controlled diabetic, but he's been taking a bucket of supplements for a long time, and his coronary calcium score at age 70 was 20. Now, the average coronary calcium score for a 70-year-old is 200, but this man's very diligent with his lifestyle and takes a bucket of supplements. But I think, again, you have to be like me, an anally retentive neurotic, to do this every day. And I've been taking a bucket of supplements every day for about 20 years.
It must be our schooling, Ross. It must be our schooling that had this influence, you know.
Well, just on that. Can we just digress to multivitamins for a second? There's a shonky little place in the US called Harvard, one of the great learning institutions in the world. And Harvard's been doing this trial that you're well aware of for the last 30 years, the health professionals trial in males and females. And 180,000 people have been involved in these trials for 30 years in varying things. So they've looked at every health parameter in these people. Now, just focusing on multivitamins for a second, they found that people who take a multivitamin a day up to 10 years, this was in the male component, randomized controlled trial, there was absolutely no benefit in taking multivitamin. But when they analysed the data at 10 years, so up to 10 years, no benefit, at 10 years, an 8% reduction in cataracts and common cancers. You say, 8% is not much, but it's statistically significant. So, I mean, it's there. And if you can reduce something by about 8%, why not do it? Then they analysed the observational data in the women at 15 years, 75% reduction in bowel cancer, 25% reduction in breast cancer, 23% reduction in cardiovascular disease just by taking a multivitamin every day. Then they looked at the data in the doctors who persisted with the multivitamin for 20 years, as opposed to those who didn't, wasn't randomized control because they'd finished that part of the study, but still observational trial, a 44% reduction in cardiovascular disease just by swallowing a multivitamin every day. But how many anally retentive neurotics are compliant? Because here's the problem with medicine. If you or I prescribe any sort of therapies to anyone, after 12 months, 50% of people have stopped because Homo sapiens as a species are a sorry lot. And they just don't follow the advice of experts, whether it's medical advice, legal advice, accounting advice. People just run their own show. And I've got to say, after 40 years of practicing medicine, the people in my practice who do the best are people who firstly follow the 5 keys of being healthy. That's 80% of their management. No addictions, good quality sleep, good quality eating and less of it, 3 to 5 hours of exercise, and most importantly, happiness. And it's been shown in the Morgan trial from Holland, Morgen trial from Holland, people who do that the best, and that's less than 10% of the community, compared with people who do that the worst, have an 83% reduction in cardiovascular disease. So to me, I say to the patients, 80% of what you do has got nothing to do with damn doctors. It's how you look after yourself. 10% is the appropriate use of pharmaceutical drugs if you need them. And the only people who do are people who are at high risk for vascular disease. And then the other 10% is the appropriate use of supplements.
And of course, we hear so often, and I know your response to this, but I'd like you to say it anyway, that why are we doing this with just expensive urine?
Oh, taking supplements gives you expensive urine. Of course it does, but it also gives you valuable blood.
Thank you.
So what you don't need, of course, you'll urinate out. But that's fine. But what you do need, and to me, the evidence is overwhelming for the benefits of supplements in healthy people. So again, I quoted the Harvard data, taking a multivitamin as one example. I've quoted the vitamin C, the vitamin E data, but I can also quote you the Iowa women's study where they looked at, I think it was something like 30,000 women, I can't remember the actual number, 30,000 for 19 years, showing no benefit from a multivitamin. You know why? Because in Iowa, they have a crappy diet. So if you think taking a supplement is a replacement, it's not called a replacement, it's called a supplement. What is it a supplement to? It's a supplement to a healthy diet. Taking any sort of supplements will not benefit overweight people, will not benefit smokers. You've got to practice the 5 keys of being healthy and then supplement that with good quality evidence-based
Now,
supplements.
you mentioned back there about 70% insulin resistance, and you're also in the anti-aging space. And another old drug that I know is focused there is metformin. What are your thoughts on metformin?
Look, again, Dave Sinclair's done a lot of work on metformin, and I think metformin's a superb drug. I think it's one of the best drugs we have in medicine, maybe a bit like aspirin. Good, simple drug. It's inexpensive. And David's shown again, he's doing a trial at the moment in elderly people over 7 years to see its anti-aging benefits. When you look at all the studies in diabetics, there's a definite reduction not only in vascular disease, but also in cancers. A lot of people don't realize this, that diabetics, because of the modulation of the insulin-like growth factor, diabetics are at a much greater risk of getting cancers as well, the obesity-related cancers, because typically people who are insulin resistant, the different things there are tendency to diabetes, of course, blood pressure, high triglyceride, low HDL, doesn't have to be your cholesterol, and abdominal obesity. And there's so many obesity-related cancers. Most of the solid organ cancers are related to obesity. So when we think of, say, lung cancer, there is no doubt lung cancer is related to cigarettes in about 70, 80% of cases. 20 to 30% of people get lung cancer, got nothing to do with cigarettes. But there is a link between people who smoke and eat bad food and more lung cancer as opposed to people who smoke who don't eat bad food. Now, I would, look, come the revolution when I'm running the show, smoking will be banned, not just banned in public places or whatever, banned completely. I think it's, if you look at drug-related deaths in society, 80% are due to cigarettes, 17% are due to alcohol. Why? Because they're freely available. They're legal. If you make something illegal, it's harder to get, so people don't use them.
I mean, insulin resistance crops up in every single disease. And I know that we've had great success with the smoking and the plain packaging and the warnings. I was just talking to a friend last night, a colleague from Sydney High. I won't mention his name for privacy issues, but anyway, I was talking to him, and we wondered whether plain packaging should go on any sugar-bearing, product, like a cherry ripe comes in plain packaging with this product contains 4 teaspoons of sugar.
Yep,
With a
with a
warning
warning
on it.
on it.
I mean, I think we would
Yeah.
probably get an even better health outcome than we have with the plain packaging on tobacco.
Well, mate, and can I make the point here that everyone's worried about the current pandemic of coronavirus? The real pandemic of the 21st century, to quote Professor Phil Barter, one of Australia's cholesterol experts, is diabetes. The combination of diabetes and obesity, which is clearly related to insulin resistance, which is a genetic disease, 30% of Caucasians, 50% of Asians, close to 100% of people with darker or olive skin. And if you've got that gene, you're exposed to Western rubbish, then out comes all of the problems with the metabolic syndrome from insulin resistance. And that's why we need to focus on it. And that's why I use metformin like lolly water in my patients and even consider, and I don't have insulin resistance of any great degree. My HbA1c is 4.8, but I'm even thinking of taking metformin just as an anti-aging drug. I enjoy life too much to hop off this planet
Now,
early.
Ross, coming back to the visit to the cardiologist, because if you are in that higher risk group, I know a visit to the cardiologist, you put me on a machine to get my heart rate. Tell us a little bit about that stress test and what you're looking for.
Okay. Look, can I say stress testing itself, which is basically having an electrocardiogram monitored, so your heart monitored, the ECG monitored during exercise, that's been around for years and years and years, and it's a good basic test, but by itself, I think is pretty weak. I think it doesn't show you a lot of other things that I get with stress echocardiography, which I think is the best form of imaging to relate to stress testing. So what we do in my practice is we take a picture of your heart with ultrasound at rest, monitor your ECG during exercise, and as soon as you're finished, repeat the ultrasound. Now, why is that important? I'm not just looking for blockages in your arteries. I'm also looking for how your valves are working before and after, and also looking for the pressures coming out of the ventricle after your exercise as well. So I'll give you a great example there. I saw a woman who was 51 years old. When she was 48, she had coronary artery bypass grafting, which is a big deal for a woman in her 40s. But since the operation, she's been incredibly short of breath. All the tests that have been done on her by standard doctors, and she'd seen 2 or 3 cardiologists, were all normal. And she was told, it's all in your head. She came to see me. Now, her stress test was completely normal, the ECG component. But when I did the echo on her, at rest, the pressures coming out of her heart were completely normal. But at the end of exercise, the gradient, which should be less than 10 across the heart outflow tract, had gone up to 75. So she had what's called a dynamic obstruction in her heart with exercise. So I put her on a simple beta blocker, which offloads that. As shortness of breath goes away, she's fine. But she was thinking, told she had something in her head. No, she had something in her heart that was being missed and would only be picked up by a stress echocardiogram. So I don't do stress testing by itself. I think it just doesn't give you the information that you get out of a stress echo. So anyone who comes to see me, just say they're perfectly asymptomatic. A 50-year-old says, Doc, my father had a heart attack at 80. I just want to know what my heart's doing. Send them downstairs to the radiology practice under my practice that I have no financial associationship with. Get a calcium score done. Calcium score comes back 0. ECG is normal. Would I do any more tests on them? Probably a thing called an arterial stiffness measurement, which is a little probe over your wrist, which measures how stiff your arteries are as a baseline. And then if everything's good, I congratulate them. I tighten up their lifestyle. I'll probably put them on some supplements. So I'm a great believer in the bergamot derivatives from BPF 99. There's a few different versions of bergamot you can buy, but the only one I use has got this BPF 99 in it, which is a very strong 99% polyphenol extract. So I think everyone over the age of 50 should take that. It comes from Calabrian oranges. I also give them vitamin K2 if they've got calcium in their arteries, because it takes the calcium out of your arteries, puts it back in your bones, and the dose is at least 180 micrograms a day. So some people are using sprays with D3 and K2 in it. There's not enough K2 in it to have the therapeutic effect. So you've got to have 180 micrograms daily.
Yeah.
Okay. And then if I've got anyone on a statin or anyone wants energy, I give them ubiquinol. So the dose of ubiquinol I use is 150 milligrams daily. And there's been a number of studies to show, firstly, statins deplete CoQ10 in your mitochondria through a pathway in the mitochondria called complex 3. It's been published. Other studies have shown that statins lower CoQ10 in your bloodstream, and other studies have shown about a 50% reduction in muscle pain and weakness in people who are given ubiquinol to combat that if they're on a statin. Now, what about ubiquinol? I take it myself, A, because I'm an anally retentive neurotic, but B, it gives me energy. So I take it purely for energy. There's some work in sportsmen, in stress management, in sleep, that it improves all of those parameters as well. So I have what I call my cardiac protocol, which involves the bergamot product, ubiquinol. I use magnesium orotate because the orotate lifts up the CoQ10 in the mitochondria. So you get maximum CoQ10 production in your mitochondria with the orotate, not magnesium, but just the magnesium, the delivery vehicle for the orotate. Vitamin K2, 180 mics a day, and I also use kyolic garlic. Now, a mate of mine, Matt Budoff, is one of the top preventative cardiologists in the US. He works at UCLA Harbor in Los Angeles, and I visited Matt, and we keep in touch. He's a really brilliant preventative cardiologist. He's really one of the American experts on coronary calcium scoring, CT angiography, the whole works. And CT angiography has a place, Ron, but the place for CT angiography is, just say you came to me and you said, Ross, I've been getting this sort of weird sort of chest pain. I did a stress echo and it was equivocal, wasn't definite. I'd probably then go to a CT angiography
with
in those circumstances.
Yeah.
With the dye, if there were symptoms, but never using people who are asymptomatic. But anyhow, Matt's done a study where he used kyolic garlic, so really high potency, high concentration garlic, in people with established heart disease on CT angiography, and showed after 12 months of using high doses of this, 4 capsules a day of the standard kyolic garlic, he actually reversed coronary artery disease, which is pretty spectacular, because so many people have this misconception. Once you've got heart disease, you're stuck with it. And so when I say don't read Tolstoy if your calcium score is high, I mean if you're not going to do anything about it.
I'm back onto it. I left the bookmark in just in case.
Yeah.
But can you, if you do that, you said kyolic garlic reversed cardiovascular disease, can you then would you take a coronary calcium CT score and expect a drop in that value, in that mark?
No, I wouldn't care about that because, for example, statins increase your coronary calcium score, because I don't care about the calcium score. Just let me show you this. There's a donut. Imagine the donut, the fat sitting in the wall, all the blood's going through the middle. That's how an artery works. The fat builds up like this. As the fat builds up, the body throws in calcium to act as a scaffold to stop the thing from breaking down. Because what happens in a heart attack is that the fatty plaque suddenly goes, cracks open. So the calcium actually protects you. So I don't care about the calcium. It just tells me you've got fat. So what I do with the coronary calcium score, and the practice underneath my office does this routinely, and I've got to ask other practices and explain to them the importance of measuring plaque volume. So you don't not only get the calcium score, but you also get the plaque volume. So I'll give you a great example there. If your volume is pretty close to the score, that means your plaques are relatively unstable. So what I do is I measure that volume. Now, I had a fellow, this is an anecdote, not a clinical trial. This is just a story, but it's a powerful story. 60-year-old male, coronary calcium score of 150, plaque volume of 144. So the fat and the calcium were pretty much together. So because his calcium score was over 100, I started him on, lifestyle. The lifestyle is king, that's 80%. I gave him a statin. I gave him all the supplements I'm talking about with you. He rang me after 3 months. He said, Ross, I can't take this damn statin. I can't lift my arms. It's killing me. I'm not doing it. I'll do everything else, but I won't do the statin. So for the next 5 years, he was diligent because, as I said to you, most people don't. They're not diligent. There's so many people say, ran out of the bergamot you gave me, doctor, ubiquinol. I just haven't bothered to go get it again, or didn't feel any different, so I just stopped taking it. That sort of crappy excuse people give. But he was, like me, an anally retentive neurotic, did everything right, and came back 5 years later, about a year ago, age 65, and we repeated his calcium score. The 150 had dropped to 126, which didn't fuss me in the slightest. It was the volume I was interested in. The plaque volume had gone from 144 to 43. So with no pharmaceutical drugs at all, we'd taken 2/3 of the fat out of his arteries with the combination of all of those 5 things I said, and lifestyle most importantly. But most people aren't that
mm,
diligent, Ron.
mm,
And again, I'm not suggesting to anyone listening to this, therefore stop statins. I use that as an extra bit
mm,
of insurance, 10% of
mm.
management. But don't come into my practice with a fag hanging out of your mouth, this big fat gut, and say, "Doctor, can I have more of that Lipitor, please?"
You know, it's interesting, the cholesterol story, coming back to the debate that you had this week at the ACNEM, Australian College of Nutritional Environmental Medicine. I think what was the topic is
Cholesterol, have
have
doctors got
doctors
it
got it wrong?
wrong?
And I think the consensus from the health practitioners that were listening was you won 83 to 17. But cholesterol,
I think most of the 17 was probably the people on
giving
who
the
were giving the
debate.
debate on the other side for
but
themselves.
but cholesterol has been demonized, and for a busy medical practitioner who's doing a 7-minute consult or a 10-minute consult, a high cholesterol and a statin makes you look like you're doing something. Can you remind our listener about cholesterol, because it's actually quite important, isn't
Sure.
it?
Yeah, look, it is very important. And can I say, just imagine the fat guy goes into the doctor and says, "Doctor, I've got cholesterol." The doctor says, "I can fix that Lipitor next." So the guy walks out with his Lipitor and goes, "Oh, phew, I didn't get lectured about being fat. I can just take this and eat what I like," which is absolute garbage, by the way. It's
Mm.
scientific nonsense even to think like that. And the doctor goes, "Oh, phew, I didn't have to talk to the patient, got rid of them quickly with a script." Everyone's happy, but it's not the right thing for society to have that attitude. So cholesterol, firstly, there's this simplistic nonsense that LDL is bad and HDL is good. Cholesterol is this sterol, waxy sterol substance, fat-like substance that may get into your arteries, but it's divided basically, and even this is too simplistic, into 4 components. There is small LDL, there's large LDL. There's small HDL, there's large HDL. Small LDL is the bit that gets oxidized and is proatherogenic. Large LDL is actually good for you. It builds healthy cell membranes, cell metabolism. It's the basic ring for steroid hormones, bile salt, vitamin D metabolism. We need large LDL. Small HDL is pro-inflammatory, so that's not good for you either. Whereas large HDL pulls fat out of the arteries. So when, say, for example, a person age 50 goes to a doctor, their cholesterol's 7, their HDL's 2.5, their triglycerides 0.6, which is a very healthy profile, coronary calcium score 0, some fool wants to put them on a statin. It just doesn't make any biologic sense. And there's this nonsense that, "Oh, doctor, my cholesterol's high, therefore I'll go on a diet." Cholesterol's got nothing to do with diet. You get 70% of your cholesterol is made in your liver, made in your brain. It's not something that if you have an egg or if you have a prawn, it's not going to put cholesterol, it's not going to put fat in the wall of your arteries. It just doesn't make any biologic sense. So I'm not suggesting people should eat what they like. That's nonsense. Because we do know, for example, the only diet in the world that has good long-term data is the Mediterranean diet, which is a high-fat, high-protein, lowish carbohydrate diet. But the best carbohydrates on the planet are fruits and vegetables. 2 or 3 pieces of fruit per day, 3 to 5 servings of vegetables per day. People who do that just by themselves have the lowest rates of heart disease and cancer, and it has no effect on your cholesterol whatsoever. So I say to people, eat a sensible diet, not because of your cholesterol, but because of good health. And if you need to be on a statin, we'll know that from your coronary calcium score or from your history of heart attack, stent bypass, or atherosclerotic stroke. Stroke's a different issue because there are other causes of stroke other than atherosclerosis. So not everyone's had a stroke needs to be on a statin. But a lot of my colleagues still throw statins at people under those circumstances. So cholesterol is important. It's an important component of living. If you took the cholesterol out of someone's body, they'd be dead within 24 hours. But many people are eating, especially a high refined diet, this processed packaged muck masquerading as food in a box. And they're the people that are getting worse insulin resistance. LP(a), again, you can be the fittest person on the planet, do all the right things. If your LP(a) is high and it's not being managed, you can still have heart disease. The worst coronary calcium score I have, Ron, is a 68-year-old man in the fitness industry. Wait for this: normal cholesterol, blood pressure, never smoked, not diabetic, no family history. So no risk factors for heart disease at all, but he has a high lipoprotein(a). His coronary calcium score is 8,500.
Wow.
And his arteries were like porcelain pipes at the age of 68, needed bypass surgery. And that was 9 years ago. And he sent me an email a couple of years ago with a picture of him and his mates winning their latest basketball grand final. And then I saw him a few months ago. He's doing fine, but he's on a statin, he's on all the supplements, and he looks after himself beautifully, so he'll live to his 100.
And do you think that's a genetic component there?
It's totally genetic. Nothing else. But had he been a profligate self-abuser, he probably would have died in his 40s and 50s because his genetics were so bad. And not everyone with a high lipoprotein(a) will go on to have heart disease, because lipoprotein(a), like anything, it's not always equal. So some lipoprotein(a)s are very benign, some aren't. And there's a different biologic reasons for that, which I won't go into. But you just have to look at people's vascular risk with their lipoprotein(a). So if they're at low risk, I just give them CE and lysine and tell them to keep their lifestyle tight, and bergamot, of course. If they're at high risk, then I'll be very aggressive with their management. And when this antisense oligonucleotide becomes available, and I'll use that. Now, what I was going to say before, I spoke about the nanotechnology, but I also think we're moving to micropatch therapy. So instead of having an injectable once a month, it'll just be a patch on your arm. There's a couple of research laboratories, one in South Korea, one in North Carolina, where they've developed this patch, and this is extraordinary, where they put the patch on the arm, it measures blood sugar real time and injects insulin based on that into this micropatch, completely painless. So the management of diabetes will just be a patch on your arm in about 10 years' time, rather than people having to inject themselves and check their finger sugar levels and all that sort of stuff, which is really, imagine the imposition in your life.
Now, you mentioned compounding. We're going back to our old days in pharmacy, and I think that is an exciting prospect, because we recently I've just spoken to Gerald Quigley,
Oh, good. My mate Gerald.
And he's coming up to Sydney, Ross, and I said we'd go out and have a steak and some red wine together. And anyway, but Gerald, of course, grew up in the compounding times. I mean, that is an exciting possibility, isn't it? To tailor medication and supplement into one tablet.
Yeah, well, isn't it weird to actually look at everyone as an individual rather than this ridiculous one-size-fits-all? So you have a heart attack in a hospital, and look, to give them their due, the best place to be if you're getting severe chest pain, 000, get to a hospital. They put a stent in your arteries. The acute problem is cured by the stent. The chronic problem is not fixed at all. And everyone comes out of the hospital on their 80 milligrams of Lipitor or their 40 milligrams of Crestor, low-dose aspirin, another blood thinner on top of that, a beta blocker, and an ACE inhibitor. And these people have been bombarded. They've been on drugs before. They have a heart attack, and they're on all of these drugs. They feel dreadful. Everybody should have their health individualized and have a personalized program for them. And again, I think we're moving towards a swab in your mouth, mapping your whole genes to say, okay, Ron, through your lifetime, you might be at a 40% chance for a heart attack, a 60% chance for this or that condition. So let's start working on it now so it doesn't happen. And I really think we are headed towards the age of personalised medicine where we'll be able to do all of these things with better genetic.
Interesting you should say that, because I've been exploring a platform that I've been starting to use clinically, Self-Decode, which does give you that kind of profile, and it's based on and the advice is based on functional approach, not pharmaceutical. But as a dentist, we hear a lot about the link between periodontal health and cardiovascular disease, and I'm interested to hear your perspective on that, because I'm on a chat group of various people talking about the Thinks group, the cholesterol skeptics group with Ufa Rashnikov. And there are some interesting backwards and forwards about the link between gum disease and cardiovascular disease. What's your view of that?
Oh, I think the link's highly established. If you have any site of chronic inflammation in the body, and the mouth is a huge area for that, I'm actually speaking to the expert on this, but the evidence for any chronic inflammatory condition anywhere, there's a strong link with heart disease, because you're then saying to your immune system, you've got to be activated in dealing with this stuff. So it's almost like collateral damage. The immune system's trying to deal with this dreadful periodontal disease, and so it's activated, it's hyped up. So it's like a security guard on on some sort of drug or cocaine, he's going to be all hyped up and ready to go. And so he'll then see this innocent piece of fat. He's got running around the body, innocent piece of fat sitting in the coronary arteries because he's been hyperactivated by the mouth. And he'll just say, I'll rip into that one again. So that's how it happens. The foot soldiers, the macrophages get overactivated by working on the mouth, and they just rip into the coronary arteries. So chronic inflammation is a huge issue, and it's something that needs to be addressed. And thank God we have visionaries like yourself who are working in this area and have promoted this as an important part. I mean, the mouth is what's the John Donne book, for whom the bell tolls, no man is an island. And again, the mouth is not something separate. It's part of the body. It's like the gut. We're learning so much about the entire microbiome, the microbiome in the mouth, the microbiome in the gut, and how closely linked that is to all aspects of
Ross,
health.
it's always great to have a checkup with you. You mentioned it very quickly before we finish, because I think you can't say it often enough. Your 5, say it a little bit slower, because you said that very quickly, and I think people need to hear it, need to focus on it, because it's such an important message.
Yeah. Look, and can I say, if people follow these 5 things I'm about to say, you reduce your risk for all diseases somewhere between 70 to 80%, regardless of your genetics. So had my guy with a calcium score of 8,500 been a profligate self-abuser, he would have been off the planet years ago. So the 5 keys of being healthy. Number 1, quit all addictions. You cannot be healthy and smoke, drink too much alcohol, and too much alcohol is anything more than 2 standard drinks a day. And I think we should all have at least 1 day a week off alcohol for one reason, not to give your body a rest, but to prove to you that you can. Because if you can't have that day off, you've got a problem. And number 3, no illegal drugs should be used. So I'm on a board of a company that's developing medical cannabis around the world. I completely support that, but no one should smoke marijuana. It is dangerous. All right. So it's number 1, quit all addictions. Number 2, 7 to 8 hours of good quality sleep per night is as good for your body as not smoking. No doubt about that. So develop a good quality sleep habit. Go to bed in the evening at the same time, wake up in the morning at the same time. Sleep in a cool, dark room. Get all electronics out of your bedroom, because they have electromagnetic radiation, keeps you awake. And there's many other things about sleep. That's another hour's lecture. Number 3, nutrition. Eat less food, eat more natural food. All of us should be having 2 or 3 pieces of fruit per day, 3 to 5 servings of vegetables per day, and tragically, less than 10% of people do. Number 4, second best drug on the planet, 3 to 5 hours every week of moderate exertion. And it should be about 2/3 cardio, 1/3 resistance training. And people who do just that simple thing of 3 to 5 hours a week of exercise, Ron, reduce their risk for heart disease, cancer, Alzheimer's, diabetes, depression by 30%, osteoporosis 50%. You drop your blood pressure and you sleep better. There's no pharmaceutical preparation known to man that comes anywhere near exercise. The best drug on the planet is happiness. And happiness to me is divided into 2 things: internal happiness and external happiness. So, for example, the Grant trial from Harvard University, 75-year trial, showed the one key to health and happiness is to have someone else in your life who loves and cares for you, who you love and care for. It's much more important than your damn cholesterol level. And I've got to say, in 40 years of practicing medicine, I've not seen one person who had a heart attack, stroke, bypass, stent, sudden death, who wasn't under some form of stress at the time. One of the 5 stressors: emotional stress, mental stress, excessive extremes of physical stress, pharmacologic stress, legal or illegal, and infective stress. So to me, cultivating happiness in your life, cultivating good relationships with people, loving your partner, loving your children, all of those important, simple things. There's a wonderful saying, Ron, climbing the ladder to success to find you're on the wrong wall. Get onto the right wall. The right wall is being internally happy. And look, shit happens to everybody. It's how you deal with it that's important. And it's the peace you have inside. One simple tip I can give everybody, something I've been doing for 30 years every day, half an hour meditation. So to have a meditation practice, to try and declutter your life, be as calm as you can, love the people around you, and also develop internal happiness, which in itself is another hour's lecture that I could talk about as well. But
Ross, always such a pleasure to catch up with you. Thank you so much for sharing your wisdom and time with us today.
Ron, anytime I get to chat with my mate Ron Ehrlich, who is one of the great people in this country, it's always a pleasure for me.
Thanks,
So thank
Ron.
you so much.
Well, you'd have to listen to that podcast again. I know I have to. I certainly have to read the transcript. I mean, Ross is just such a wealth of information, and I love his open mind and the way he puts it all together and the way he articulates it so clearly. And he's a specialist cardiologist, an integrative cardiologist. He may not use this word, but in my opinion, he's a holistic cardiologist, and I think they're the kind of practitioners we should be seeking out. And good on him. And I'm as he mentioned at the beginning of this. He's been a friend for many, many years. We started in school together at Sydney High in 1968, so do the maths on that. And he's been my cardiologist for the last 10, 15 years. And he continues to be a good friend and colleague, and I have so much respect for him. He, of course, has all of those radio programs. He's written many books. We'll have links to his site. I hope this finds you well. Until next time, this is Dr. Ron Ehrlich. This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.